Welcome to AAPHD's first webinar of 2026. I'm David Pena. I'm the Executive Director for AAPHD. A few announcements before we start. If you're a member of AAPHD, thank you for your continued support. If you're not a member of AAPHD, we encourage you to visit our website, learn about our programs, our mission, and join our association. Also, if you have not registered for the upcoming National Oral Health Conference, which we are co-hosting with ASCDD, I encourage you to register by tomorrow to take advantage of the early bird pricing. For today's webinar, everybody will be on mute. At the end of the webinar, we will have a Q&A with the presenters. Please post your questions on the chat, and at the very end, we will address as many questions as we can, time permitting. Now it gives me great pleasure to introduce today's presenters, Dr. Jill Herndon and Dr. Julie Reynolds. Thank you.
Thanks so much, David, and good morning or afternoon, everyone, depending on where you are. It is so great to be with you. I see lots of friendly faces and a lot that I don't know, so thank you for joining. And we're going to talk about advancing measurement to improve dental.
Dr. Reynolds, you seem to have muted yourself.
Thank you. Appreciate that. We'll start over. Good to be with you all. Thanks, Megan, if that was you. It's great to be with all of you today. I know many of you already, but for those that don't know me, my name is Julie Reynolds. I am currently the president-elect of AAPHD, and in my day job, I'm a faculty member at the University of Iowa College of Dentistry. I also have the pleasure of serving as AAPHD's representative on the Dental Quality Alliance and served as chair of the Alliance in 2025. The DQA's work is very synergistic with public health dentistry, and I'm very excited to raise awareness in our public health dentistry community about DQA's activities and its impact, and to show how we as public health dentistry professionals can use DQA resources in our daily work. I'm joined by my dear colleague today, Dr. Jill Herndon, who is a health economist by training. She was on the faculty at the University of Florida doing Medicaid evaluation work for many years, and most recently for the past 10 plus years has served as DQA's lead methodologist and really the backbone and engine for all of its measure development and maintenance work. I cannot say enough about how important Jill's contributions have been to this field, and it's really a privilege to introduce her to this audience. Before we move forward with the presentation, I would love to get a sense of who is in the Zoom room today. So if you are comfortable, could you please drop a few pieces of information in the chat, including your name, where you are located, and your role and affiliation, so we can see who is here with us. We'll keep an eye on that. Thank you, everyone, for sharing, but we'll keep going in the meantime. So we can go to the next slide, please. Neither Dr. Herndon nor myself have any conflicts of interest to disclose today. So as I mentioned, DQA is an alliance of organizations that collectively really care a lot about dental quality measurement and improvement. And AAPHD has been an organizational member since the DQA's founding. That means that AAPHD pays dues to be a voting member of the DQA so that we can be at the table and help drive the DQA's work. Next slide, please. And it makes a lot of sense for AAPHD to be really actively engaged with this alliance because we really care about the same things. We in public health dentistry are concerned about improving dental care access and equity, with improving population oral health, with translating evidence into practice, and with QI, quality improvement in dental care. We also care a lot about using engaged approaches for decision making, which DQA does very well. So APHD and the DQA share very similar goals, and the DQA's work to develop really rigorous dental quality metrics serves as a foundation for a lot of the activities that we in public health dentistry are engaged in. Next slide, please. Public health dentistry professionals are no strangers to measurement and improvement. We use data and we use QI every single day in our work, many of us, whether it is in research, administration, informing our advocacy activities, iterating on our teaching methods, or evaluating public health programs. And we know the importance of rigorous, standardized measurement when there are stakes involved. In our world, we talk a lot about the idea of value-based care or pay for performance as really promising approaches for health system reform. But these models are only possible if we have robust, validated quality metrics that can be used to compare performance across entities and over time. So we are really lucky to have DQA leading the way in this effort to develop these robust quality metrics. And we're going to hear today about how DQA goes about its work and one of its key resources, which is the state Medicaid quality dashboard. So let's go to the next slide. Our learning objectives for today are to talk about the DQA's process for measure development and maintenance, to navigate the dashboard, to evaluate state and national trends in Medicaid dental care access and quality.
I'm good. What's up?
And to identify how quality measurement can support QI. And with that, I will turn it over to Dr. Herndon. Dr. Herndon, if you are talking, we cannot hear you. You're muted.
Okay, let me try again. Okay.
We were both guilty.
Good company to be in. Well, okay, thank you so much. We are so happy to be here with you today. And as Julie noted, I've had the good fortune to be involved in the DQA's measure development efforts for more than 10 years now. So we'll start with some background on the DQA and its quality measurement activities. And our focus today is on quality measures, but we should take a moment to note that what we're really aiming for is improvement in care quality and ultimately outcomes. There are different models for improvement, but the models all start with the goals. So what do you want to improve, for whom, and by how much? And what are the interventions or changes that will result in that improvement? Measures are a component of all of the different models. And the purpose of measurement is to support improvement. Measures let you know where you're starting from, whether you're indeed moving forward on the path to improvement, how well you're making forward progress, and whether you're sustaining that progress. And just a few examples of improvement goals that DQA measures can support include increasing the percentage of children established into routine care, reducing the number of caries-related ED visits, and improving medical dental integration. Until relatively recently, though, we really didn't have much in the way of good dental measures. In fact, in 2011, I've shown one here, but there were actually two different IOM reports that highlighted the lack of dental quality measures as a barrier to understanding oral health care quality and to improving care. Around the same time, recognizing this void, the Centers for Medicare and Medicaid Services asked the American Dental Association to convene a group specifically to develop quality measures, and that led to the creation of the Dental Quality Alliance. As Julie noted, the DQA brings together a broad range of engaged parties, including AAPHD, that work together to develop evidence-based measures using consensus building processes. And the people around the DQA table come in with many different perspectives and different needs. So the DQA's approach focuses on transparency and getting input from the broader oral health community as it reaches different milestones from measure conceptualization to measure specification to measure testing. And key elements of measure testing include first, assessing the measure's importance, which is the extent to which the measure identifies a care gap and addresses it, is evidence-based, and has the potential to improve quality. Feasibility refers to implementation burden. For example, the extent to which data elements needed to calculate the measure are already available. Reliability and validity ensure that the measure provides consistent and credible information about the quality of care. And usability is the extent to which the measure is actionable and actually gets put into use to drive improvement. This rigorous testing basically verifies the quality of the quality measure. And measurement occurs across different levels of the healthcare system and is typically driven from the system level to the practice level. So, for example, CMS identifies priority quality improvement areas that are reflected in the core measure sets for Medicaid and CHIP programs. The programs, in turn, hold their contracted medical and dental plans accountable, and those plans, in turn, hold their network practices accountable. And across these different program, plan, and practice levels, there are different types of data sources available for measurement, which we'll talk about in just a minute. A key question, though, is what population is the focus of measurement? So we might be interested in looking at the percentage of children enrolled in a Medicaid program who receive an oral evaluation during the year. This is the level of measurement for the CMS core sets and also for the DQA dashboard that we'll be looking at shortly. At the plan level, we're looking at the percentage of children enrolled in a specific plan, like a Delta dental plan, and then going to the level of the care site, looking at the percentage of children in a specific clinic or practice who are getting recommended care. And why this matters is that measures are developed and specified for each specific reporting level. It is not one size fits all because the data sources and other aspects of measurement may vary across the different levels. And we want to make sure that we're getting accurate and valid measurement at each level. And that brings us to our next question. What data are available? Ideally, we would want to aggregate from practice to plan to program seamlessly, preserving the richness contained in the electronic patient record. However, we know that our health IT systems are simply not there yet. At the program and plan levels, we rely primarily on administrative databases that have enrollment and claims data. At the practice level, we do have the opportunity to use data from the electronic patient records, although we know the feasibility of extracting that information for measurement purposes varies quite a bit from setting to setting. Patient surveys are used to collect information directly from the patient or the patient's caregiver on experience with care, patient-reported outcomes, but patient-reported measures currently have limited applications in dentistry, although we are evolving there as well. And because measurement tends to be driven from the system level, the DQA's initial measure development focused on program and plan level measures. This was also more feasible because claims and enrollment data were more readily available and had greater consistency than the data in electronic patient records. Okay, so remember that the DQA was formed in 2010 to address that identified need for standardized and validated measures. This shows key milestones that illustrate just how far we've come. After significant testing, the DQA released the starter set of pediatric measures in 2013. Several of those received National Quality Forum endorsement the following year after undergoing rigorous review. In 2015, the measure of sealant placement was included as the first DQA measure in the CMS Medicaid and CHIP child core set. And there was a clinic and practice level counterpart of this measure that was specified for use with electronic patient record data that was included in HRSA UDS reporting by FQHCs. In 2016, the DQA released its first measures for adults, in 2022 for pregnant beneficiaries, and the number of measures incorporated in the CMS core sets has also expanded significantly over the years. The DQA engages in ongoing measure development as well as measure maintenance. And that's when the measures themselves undergo review every year with user feedback solicited. So we can make sure the measures are working as intended and are still relevant. And we're actually just getting ready to kick that process off for this year. So look for a request for public comment. The DQA also provides implementation guidance and education, and all of these activities are designed to support improvement efforts. So today we now have a range of standardized and rigorously tested oral health care measures with broad adoption, including by CMS, HRSA, state marketplaces, state Medicaid programs. We've noted the measures included in the CMS core sets, and we've also noted with STARS, measures that support medical dental integration because we know this is increasingly a priority area. And this just brings the DQA measures that are currently in the CMS core sets into clearer focus. The first three measures, oral evaluation, topical fluoride, and sealants on permanent first molars, they've been in the child core set and they're now required to be reported by all state Medicaid programs. The fourth measure, oral evaluation during pregnancy, is a relatively new measure, and it's in both the child and the adult core sets, and which set is based on age. After many years of diligent effort, dental measures made it into the adult core set. So in addition to the pregnancy measure, the measure of non-traumatic dental condition related ED visits is included. And we are really excited to report that CMS has just adopted oral evaluation for adults with diabetes to be included for voluntary reporting in 2027. There's also a health home core set for children, and the pediatric measure of oral evaluation is included in that as well. So some terrific progress. We talked about how measurement starts at the system level, but when we think about improvement and how that actually occurs, that really has to happen by the practices and clinicians that have direct contact with patients. So we really need aligned measures for practices so that they can assess and improve the care that they are providing. And all of this has to work together. So improvement and practice level measures should be aligned with and feed into improvement at the program and plan levels. And so we wanted to let you know that the DQA currently has a work group that is specifically focused on developing testing measures for implementation at the practice level. So just like we have standardized measures at the program level, we will also have them at the practice level. And because alignment is so important, we start with the program and plan level measures, and then we adapt them for practice-based measurement. And a key component of this is figuring out the method for associating patients to practices. So identifying which group of patients the practice should be responsible for when it comes to measurement. And this has been a particular focus of the work group's efforts. The first set of measures was based on claims data, building off of those existing program and plan level claims-based measures so that a dental plan, for example, can calculate measures for the practices in its network using its claims database. The work group is now focusing on measures calculated using the more robust electronic patient record data within practices. And this is the starter set of claims-based measures for implementation at the practice level. All but one have completed testing, been approved by the DQA, with the final reports and specifications posted on the DQA website. And all of the DQA measure specifications are posted on the DQA website. Okay, so now let's transition from developing measures to actually using them. Okay, so when deciding which measures to adopt, we recommend starting with whatever your care goal is. What is it that you want to improve? And then selecting a set of measures, ideally a set that spans access, process, and outcomes. Sometimes there's a temptation to focus on just one or two measures, and that may not give you a really robust assessment of quality of care. Another important consideration is implementation feasibility. If you're implementing a measure within your system, whether it's a Medicaid program, plan, or practice, you want to ensure in advance the data availability, completeness, and quality within that particular system. We also stress that improving data collection and quality is really a key part of the improvement process. Of course, once you start measuring, continue to remeasure over time to assess and sustain improvement. So this example measure set addresses the goal of reducing caries-related ED visits. Oral evaluation and care continuity address access to the dental care system. Topical fluoride and sealants on permanent first molars are evidence-based caries preventive services. And with both better access to the dental care system and specifically to preventive services, we would expect rates of caries-related ED visits to be lower. And we'll actually look at this a little bit when we get to the dashboard. Speaking of which, it does require resources to implement measures. And the DQA thought, well, wouldn't it be great to have a dashboard with the measures already reported so that states and others can focus on the actual work of improvement? So that's exactly what we did. The measures are all calculated using Transformed Medicaid Statistical Information System, or TMSIS data, available through CMS. So the dashboard represents measurement for state Medicaid and CHIP beneficiaries, and we currently have data reported through 2022. These data are very rich. They include Medicaid and CHIP enrollment and claims data for all states. It includes medical, dental, and pharmacy claims, both facility and professional claims for both inpatient and outpatient services. DQA has access to these through a data use agreement with CMS to conduct oral healthcare quality measurement research, with one of the outputs being the dashboard. And I just cannot tell you how incredible it is to have access to such rich data, because that did not exist before. I want to give just a very brief orientation to the dashboard features before we dive into it itself. There's 3 populations that we report on. There's 17 measures for children, and there's also measures for adults and pregnant beneficiaries. And then for each of the 3 populations, there's 4 reports. The main state report gives options for selecting the measure, state, and year, and the ability to stratify by population characteristics. There are additional reports that give you the ability to compare scores for different measures for the same state, compare states relative to a national score, and charts with trends over time at the national and state levels. And there's also some important notes that provide very useful contextual information. And one of those notes is individualized quality assessments for each measure. And this is really a key feature of the dashboard because, as we all know, claims data quality is not perfect. And the DQA decided that it was important to report measure scores for all states, but also to note the data quality associated with each score to provide an indication of how reliable that score is likely to be. So for each state, measure, and year, we identified all of the data elements needed to calculate the measure. We started with the data quality assessments from the CMS Data Quality Atlas, but then we added additional assessments, especially for dental-specific fields. Our data quality assessment for each measure reflects the data element with the highest level of concern. And we're pretty comfortable in the reliability of measure scores where underlying data quality is of low or medium concern. We are not terribly comfortable with the reliability of measure scores when data quality is of high concern or unusable. Okay, so we said scores with high concern, unusable data should not be reported, but we're reporting them in the dashboard. Why are we doing this? We felt that reporting all the scores with the data quality assessment provides the greatest transparency. It enables both users and states to understand how data quality impacts measure score performance, and states can work on addressing the quality of their data submissions to CMS. The dashboard's continually evolving and growing. We just got access to 2023 data, and we'll be running the measures soon to update them through 2023. Deeply appreciative for having access to these data and the really helpful technical assistance resources available through CMS. So now for the main event, I will switch my screen share to the dashboard. So just give me 1 moment. I'm going to stop this share, and then I'm going to open a new share. And here it is. And that you should be seeing. And then let me just get myself situated. Okay. So when you're looking for the dashboard, when you get to the DQA's website, you want to go to the Improvement Initiatives tab and you just scroll down and you'll find the dashboard. And then there's a lot of notes and additional information below that can be helpful in understanding that some of the features of the dashboard. And you can see that we have our three populations here. So we have a report for each population. And then there's drop downs here for selections for state, year. It's always going to default to the most recent 5 years, but it does go back to 2016. So you can select and deselect program, drop down for measures, and then stratifications. And then the four reports that I referenced are along the top. And down here, you see the data quality indicator, and it's specific to the state, the measure, and the year. So that's kind of the layout. And so I want to start by illustrating how the dashboard can allow us to look at sets of measures, like that example of caries related ED visits that we talked about. So I cheated a little bit and preloaded the tab so you wouldn't be watching me spend a lot of time navigating through the dashboard. You can do that on your own, and we encourage you to do that. So you can see right now we're in the National Comparison Report for children. We've selected caries-related ED visits. The green line gives you the national score. And there is a note here, and it says it's based on data from 49 states with data quality of low and medium concerns. So we only base the national score where states have acceptable data quality. So if there's a bunch of states who have a score of 0 because they have terrible data quality, we don't want to factor that into the national score because it's not reflecting actual performance. It's reflecting poor data quality. By 2022, you see we have 49 states. So data quality has really improved over the years. So all but one state are included. And then, or I guess two, because we also have the District of Columbia. And then a couple of notes about caries-related ED visits. This measure is a little bit different from the other measures in two ways. First of all, this number is not a percentage. It is, all the other measures are, but this one is not. It's a number of visits per 100,000 member months. So just wanted to flag that. The other thing is that a higher score is lower performing because we want fewer caries related ED visits and not more. And so the higher performing is lower performance. And we see Ohio on this end with a higher score relative to the national. And then if we flip along here to the right, use the scroller, we can see Texas is all the way here and has the lowest score, which is higher performing. So let's see how Ohio and Texas are doing in terms of measures of access and prevention. So now I'm in the state measure comparison report. I've got Ohio, and then you can select which measures. I've selected the same ones that were in that example: care continuity, oral evaluation, sealants, and topical fluoride. The light blue bar is the state value. The dark blue bar is the national value. And you can see for all of these, Ohio's scores are below the national value. So it's lower performing on all these four measures of access and prevention. Now let's go to Texas. And it's reverse. The state score is above the national score, and Texas is higher performing of all of these. And that's kind of what we would have suspected or predicted. And so you can see, again, the dashboard allows you to compare measures within a state or to compare states relative to a national value. Okay, so the next thing I wanted to do was just give a little bit of information on the state report. So we have Alaska selected. We have oral evaluation, which is one of the measures in the child core set. And this is looking at the percentage of children who had at least one comprehensive or periodic oral evaluation during the year. And we've got the age stratification selected. And this pattern is pretty typical for dental measures with the lower performance among the youngest kids and the older kids. And with every stratification report, you'll always have the state score and the national score off to the right as contextual comparative information for reference when you're looking at the stratifications. And there's a number of stratifications here. We have age and geographic location and language. Well, wait a minute here. Uh, Language scores are not reported here. So you might be going, well, what's happening? Well, look down here at the note. It says language stratification not reported. Missing data is 90%. So when the stratification variable itself, whether it be age, race, ethnicity, language, whatever, is missing at a rate of more than 10%, we don't report that stratification. So let's go to race and ethnicity. It's reportable, but note that one category is not reported. In this case, when we look at the note, it says denominator is less than 30. So we also don't report for a specific category if the denominator is less than 30. Okay. So the next thing I want to illustrate is two things. You get two for one here. One is the distinction between dental and so you'll see some of the measures have a dental option and an oral health services option in either. And also this example will illustrate how you can see policies reflected in the measure scores. So far, we've been looking at the quote unquote dental services of the measures, which is services provided by or under the supervision of a dentist. But we know that medical providers play an important role in oral health, for example, when physicians apply topical fluoride. And North Carolina is a great example of this, right, with its Into the Mouths of Babes programs. So we have North Carolina selected, and we have topical fluoride, the dental services version, and I have age stratifications because we're going to focus just on those youngest kids, the ones who are most likely to get topical fluoride from medical primary care providers. Okay, so right now we're in the dental services version. And the topical fluoride measure always looks for at least 2 topical fluoride applications during the year. And so we see that 8% of children in North Carolina's Medicaid program got at least 2 topical fluoride applications specifically from dental providers. Now let's see what happens if we pick the oral health version. It jumps up to 21% for 1 to 2-year-olds. Not surprising because that's what North Carolina's been working very hard on for a long time. Now, let's suppose that we go to Washington State, which has the ABCD program, which is focused on connecting kids with dental providers at a young age. We're in the oral health version, Washington State. This is 2.2% of getting at least 2 topical fluoride applications specifically from, for example, medical care, primary care providers and not dental providers. If we go to the dental services version, what's going to happen? It's going to jump up because that's the focus of Washington's program. So you can see there are different approaches for increasing access reflected in here. Now, you might say, I don't care who does it. All I care about is that kids get at least 2 topical fluoride applications during the year. Well, that's the dental or oral health services version, and it goes up a little bit more. In Washington State, it's about 19% of kids who got at least 2 topical fluoride applications, agnostic to who actually delivered it. And that's why we have all 3 versions of this measure is it allows you to look at the overall, but it also allows states to understand what percentage is coming from the medical system, what percentage is coming from the dental system, and also it allows them to monitor progress and understand the effects of interventions that may be effectuated through one system or the other. Okay, the next thing is I wanted to illustrate why the data quality indicators are so important. So North Carolina, going back to North Carolina, we like going to North Carolina. North Carolina was always one of the go-to states because always had like really terrific data quality. And so I'm back in the state measure comparison report with our measures of care continuity, oral evaluation, sealants, and topical fluoride. And North Carolina has high performance on 3 of the 4 measures. And actually, I'm going to pick 2021 on 3 of the 4 measures. But look at sealants, it's 15% compared to a national value of 52%, almost 52%. But look at the data quality indicators here. The ones where it's higher performing, there's no data quality concerns. For sealants, it's unusable. Well, what the heck happened? For several years, North Carolina had a lot of missing data related to tooth number. And that's a critical data element for this measure that focuses specifically on permanent first molars. So it shows how poor data quality on just one data element can really affect the performance score. And that's exactly why we report the data quality. It's not intended to be a negative reflection on the state. It's actually the opposite. Without this data quality indicator, you might think North Carolina is doing a really crummy job of sealant placement. What the data quality indicator says is this is probably not reflective of actual performance, and you should not use this. So that's the data quality. And then I'm just going to quickly introduce you to the adult dashboard. I have adults with diabetes oral evaluation selected for the state of Alaska in several years. And I just want to note a couple of things that are different in the adult report compared to the child and pregnant beneficiary reports. One is we have a stratification for Medicaid, Medicare dual eligibles. The other thing is below the table, in addition to our data quality notes, we indicate the extent of adult dental benefits coverage because both poor data quality and poor dental benefits coverage will be associated with lower performance scores. So important contextual information. Now, Alaska has extensive dental benefits coverage in every year. If we go to Alabama, no dental benefits coverage and there's no scores. Like the data quality is fine. It's just there's no services to report. And then let's go, I want to quickly go to Delaware. In Delaware, there was actually a change in coverage. It went from none to limited. And the year it went to limited, you see a jump up in the scores. So that's the dental benefits coverage. And then with the national comparison report, when we do the national value, it's not only based on states with acceptable data quality, but it's also based only on those states that have extensive adult dental benefits in that year. So it's the best case scenario, right? So for adults with diabetes that had at least one periodic or comprehensive oral evaluation during the year, in the best case scenario, right? To good data quality, extensive dental benefits coverage, the national score is only 19%. And even in the highest performing state, it's only 29%. So a big opportunity for improvement, which hopefully will get some more traction now that this measure has been adopted into the Medicaid adult core set. And then the one report we haven't looked at is the time trend report. You can look national and states. We do, with almost every measure, see that dip in 2020 due to COVID-19's impacts on healthcare service use. And then you can add in states to this report. And then last but not least, we have the 2 pregnancy measures. Utilization of service gives an indicator of broad access to dental services during pregnancy. And then oral evaluation is an indicator of access that signifies that the individual may be more likely to be connected into routine care compared to the very broad utilization of services. There is so much in the dashboard. I could go on and on and on and on. I'm not going to do that. I'm going to kick this back to Julie because we want to make sure we have time to get your feedback and input and have some more dialogue. So I'm going to flip back to the PowerPoint and let's see if I do this correctly. Yes. And then there, back to Julie.
Great. Thank you so much, Jill. There is so much in the dashboard. As Dr. Herndon said, I've definitely gotten lost in it many times. I hope that you all will too. And thank you for the engagement in the chat. Great questions so far. And there are some folks on here that are on the DQA and have been really close to this topic. So feel free to keep asking and chiming in as we go along. Thank you for that. In our last few minutes, I just want to think through how those of us that are working in public health dentistry can use the breadth of DQA's resources. And I think about their resources in three buckets. We have the dashboard, we have the measures themselves, and we have educational resources. And after Jill's demo of the dashboard, I hope that your wheels are turning with all of the ways that it could be useful for your work. But from my perspective, I think the dashboard can be really useful for advocacy, for research, and for education. And I'll explore each of those a little bit. From an advocacy perspective, I think that showing how your state is doing on measures of dental care access for people with Medicaid relative to other states in particular can be an incredibly powerful advocacy message. I really want to get this dashboard into the hands of every single state oral health coalition to inform their advocacy activities. So if you're involved in your state oral health coalition, please share it with them so that they're aware that this is available. And because there are so many different measures in the dashboard, it can also be really useful to identify what specifically is going well and what needs improvement, as Jill showed us when we unpacked a couple of different states. As another example, perhaps a state has a high rate of dental sealant provision because there's a widespread school-based sealant program. So that's going really well. But if you look at the rate of kids having a comprehensive or periodic exam, a recent dental checkup, that might be really low if there are challenges finding a dentist that takes Medicaid. So it's really helpful to be able to use these measures to get at the nuances of dental care access so that advocacy messages and improvement work can be really targeted where it's most needed. I also think it's really helpful to see those measure stratifications that Jill showed, breaking out measure scores by age or by race or by geographic area so that we can target our advocacy work and our improvement efforts to reduce disparities. From a research perspective, I think this dashboard can be really useful to generate research questions. My work is in the Medicaid policy and access space, so my wheels are always turning when I look at this dashboard. And it can also be used as a primary data source for state level research, or it can be used for a lit review to inform related scholarship. I personally have had several student research mentees who have used this dashboard to contextualize their results or to review it as part of their lit review. Lots of opportunities to use the dashboard for research. From an education perspective, if any of you are doing any teaching, those of us that are in academics, about access to care or about Medicaid policy, this can be a really useful resource to include in your slides or to use as an active learning activity for students to explore on their own. I personally have content from this dashboard in my lecture slides about dental care access and Medicaid. So let's talk about the next bucket, which is the DQA measures themselves. As Jill mentioned, all of the measures and their very detailed specifications are available on the DQA website. And these measures can be useful for administrators that are overseeing quality measurement and improvement activities within their clinics or their programs, or if they're working in a dental or health plan. If a chief dental officer, for example, wanted to undergo a QI project within their clinics, they could use the DQA measures, which again have those very detailed specifications that allow them to be measured in a standardized way to measure quality and track improvement over time. On the research side, I've also seen DQA measures used in some really excellent publications recently, where DQA measures have been used to explore things like emergency department use for dental conditions, or to explore racial inequities in care quality for this population. So a lot of opportunities to use the measures themselves. And then for the last bucket, we have educational resources. We didn't talk that much about those today, but there's a whole committee within the DQA focused on education and supporting the implementation of DQA measures in practice. So its educational resources include webinars on their website that are recorded and freely available that are related to quality measurement and improvement. And my favorite is a really excellent self-paced online course that is offered through the Institute for Healthcare Improvement that grants CE credits through the ADA. I personally have taken that course myself, and I have my dental public health residents take it in preparation for a class on quality measurement and improvement. And I think the content would be really useful to anyone that's interested in an introduction to QI and dentistry, whether that's students, administrators, clinicians, or others. The class, just FYI, used to be free, but now it's only $10 to $20 and it earns 2.5 CE credits, so definitely well worth the cost. But those are just my ideas about how to use these resources. Let's go to the next slide. And I know that there's a lot of collective wisdom in this Zoom room. So I would really love to hear how you are already using DQA resources in your own work so that we can learn from one another. Or if you're not yet, how are your wheels turning? How might you use some of these resources in your work in public health dentistry in the future? Let's just go ahead and take a moment to think about this and drop some ideas in the chat. And while folks are thinking, again, my uses have been in the research space as I mentor students on their own research, teaching related to Medicaid, dental care access and quality, and using the IHI course in my teaching as well. Who else is using DQA resources in their work, and how are you thinking about it? I'm happy to drop some links in the chat, or feel free to follow up with me afterwards. Yep, I will do that right now while we're talking about it. I know that we have some state Medicaid folks in the room too, so if there are any uses within your worlds that you're looking at DQA measure results as opportunities for improvement, feel free to share that too. While folks are thinking about how they would like to use or how they are already using DQA resources in their work, let's also bring up the last slide here in case anyone has to jump off early for class or clinic or other meetings. I just want to make sure that you all have resources about the DQA accessible to you, the dashboard, all of the educational resources, and the IHI course are linked on the DQA's website. And I know that the DQA staff would be very interested in hearing how you are using their resources in your work. The goal of DQA is to make resources that are useful for folks to implement for improvement out in our various spaces, whether it's at the plan or program level or within clinical settings. So please be in touch. Yeah, thank you, Paul, for the comment. definitely useful for an advocacy perspective, and want to get this work in the hands of our state oral health coalitions that are active in this space. Yeah, thank you. There was a question in the chat about how close dentistry is to using ICD-10 codes as a way to develop outcome measures. And I wonder, Jill, if you would want to talk a little bit about some of the measures that incorporate ICD-10 within the specs.
So the program and plan level measures, the only ones that include diagnosis codes are on the medical side to identify like dental related ED visits and individuals who are pregnant and those types of things. Um, but there is also the practice and clinician work group that we talked about, and we know that there are some practice locations that are using diagnosis codes, even though if they may not be, not everybody's doing it consistently. And those locations, those practices and so forth are the types of practices that the DQA would partner with to test those measures and assess feasibility and all of those kinds of things. But it has definitely been one of the great limitations to advancing quality measurement in dentistry, even though there are also a lot of champions like the National Network for Oral Health Access and other groups that really are hoping to get more momentum behind actual adoption and um, getting that captured into the data sources used for measurement.
Thanks, Jill. And thanks for continuing to drop your ideas in the chat. I see research on emergency department use for non-traumatic dental conditions as one use, ideas for advocacy. So keep up the ideas so you all can learn from each other about how this can be useful. And if folks have questions, feel free to also share those now. You can do that either by dropping questions in the chat or using the hand raise function, and I can call on you. I see use within North Carolina Medicaid, and Dr. Casey has been so instrumental in within DQA's work. So thank you for that, Mark. Thank you, Peggy. Please share your question.
Thanks. It's just easier to ask than to type. I work with not just groups across medical dental integration, but just various health conditions. One of the things that we found in monitoring some of these preventive measures, particularly within the community health center FQHC systems, is that because of the bundled payments, because of the prospective payment systems, the PPS systems, that pulling out data on, for example, application of fluoride varnish on the medical side of the house is not always something that's easy to extract. And because they are the source of a very, large amount of primary care delivery for Medicaid populations, how have you sort of struggled through that particular question in trying to identify the actual fluoride varnish application rates in a state by claims? It's just such a tangle. And I thank you, appreciate what do you have to say?
Yeah, thank you. Jill has been very deep in the TMSIS data, so I'm going to hand that one over to you, Jill.
That is a great question, and I wish there was like a super easy, terrific answer. There is some guidance that really encourages, well, there were a couple of different things. So the bundled payment is like one issue where if a single encounter code is used to capture a group of services, So like say you have a single, I'm just giving an example, this may not be your situation, a single CDT code that um, captures, fluoride and an evaluation and, everything. It's basically just representing an encounter, but not all the individual things that happen within it. That won't get captured um, in like the fluoride measure. It might get captured in overall utilization of services measure. So one recommendation is to get those recorded into the data system, even if it's like a zero reimbursement. The medical dental connectivity, that is, of course, an ongoing challenge, right? Like, especially like within a FQHC, there's always this like, if they're co-located, everything's hunky-dory, but we know that even in co-located FQHCs and other centers, there may be separate records on the medical and dental side, and getting them to talk may not always be very easy. And a lot of times that's where the organization um, internally works to figure out how do we do a better job of getting these data, getting that coordination and so forth. And um, those are very tricky issues and they are very challenging. Um, and we see that a lot with FQHCs, and even integrated health systems where they say we've got really good access for fluoride on the dental side, but we have a lot of trouble pulling it from the medical side of our same organization. So that is definitely not a unique problem.
Good question. And also wanted to just underscore the last part of Dr. Casey's previous comment in the power of stratifying measures also by geographic location. If you're doing within state work and trying to identify where in the state are the greatest access barriers, right? There's a lot of power in sort of stratifying that by county in that case. So thank you for that. And thanks, Matt, for the tip about ensuring open communication between advocates and the state Medicaid dental program staff. What other questions do we have? We have 2 minutes. We'll make sure that we're out of here before 1 o'clock Central. I'll give folks a moment in case any wheels are turning, but I think some of the take-home messages from today are just the power and opportunities for using really high quality, standardized and robust quality measures, whether it's in a research context, an advocacy context, or in educating yourselves or your students. And that, as Dr. Glassman astutely observed as we were looking through the chat and others have talked about, we have a lot of challenges, but also a lot of need and opportunity to figure out ways to measure outcomes in dentistry, especially in the absence of widespread use of diagnosis codes. So we can all continue to advocate for a more robust and growing use of being able to document disease systematically in our delivery systems and our clinical care. Okay, everyone, I don't see any more hands up or any more questions in the chat. So I'm going to say thank you all at this point for joining us. Thank you for sharing your wisdom and your great questions. Please stay in touch with AAPHD staff for other webinar ideas and join us for webinars in the future, and with DQA to share how you're using their resources and to just stay engaged with their work in general. David, I saw you turn on your camera. Do you want to make any final remarks?
No, thank you to you and to Jill for today's session, and thanks to everybody who joined us. Look forward to seeing you on our next session. Thank you.
Take care, everyone.